Welcome everybody to this webinar, Medical Training Therapy. My name is Niels Veldhuizen. I'm a registered physiotherapist, registered occupational health physiotherapist, trainer coach. I've made this presentation for you guys and made it the first webinar presentation. I'm used to doing this presentation in front of a group of people. Now I'm staring at a screen, so it will be slightly different than normally. Nevertheless, the content is slightly adjusted than normally, but like I said, it will be an introduction in medical training therapy. And I've subdivided this presentation in 3 parts. After each part, there is a possibility to ask some questions. And in order to keep this presentation going, normally I would like to have the audience ask some questions during the presentation, but in a webinar, that's unfortunately that's not possible, because otherwise we will lose too much time. So there will be 3 moments where you can ask questions. My name is Niels Veldhuizen. I'm a registered physiotherapist, registered occupational health physiotherapist, trainer, coach. I've made this presentation for you guys. It's about medical training therapy. I've subdivided the presentation in 3 parts, and after each part there is a possibility to ask some questions. Normally I'll give these presentations in a live session with customers and with people in front of me, with a group in front of me. And then there's the opportunity to ask some questions during the presentation. It will be a bit more interactive. Unfortunately, in this webinar session, that's not possible. So we've reserved 3 parts with questions. We have 2 sessions. This today is the first one, and next week will be the second one. If there are any questions about the contents or any specific questions regarding the presentation, or maybe about the topics, you should realize that there's a possibility to make some changes and adaptations for next week. So what we can't cover today, we can cover next week. So let's make this an interactive session on a distance then. I'll start the presentation now. Like I said, this is a presentation about medical training therapy. You look at a picture of an exercise room in somewhere in the Netherlands. It's an example of many exercise rooms. Many physiotherapists have exercise rooms here in the Netherlands, and we truly see training as a therapy. In this first part, I will start with an introduction in medical training therapy and slightly describe how we work in the Netherlands. And like I said, part 3, there's a question possibility after this first session. There's a question. I see a question coming in. Can we use our microphone? Not during the presentation part, because that will be too disturbing. You can use the microphone when we have a Q&A session. Then I will enable the microphones to be used. Is that okay? Okay. When you look at at exercise, there has been a shift in the Netherlands in therapy. When you look at the early 1980s up until now, there's been a shift more towards exercise and active therapy. Patients are more active themselves, and they train and exercise in order to get healthier, get better, to recover. In the early 80s and 70s, there were more, as we call the passive therapies, where the physiotherapists were more active. There's been a shift towards patients being active themselves. That's based on best available evidence, because evidence and scientific research showed that exercise therapy in the end is the most effective therapy. That doesn't say that other therapies aren't active and aren't effective. I'm quite in favor of using the whole package, but you should realize that you should know when to actually use which part of the therapy. When you talk about exercise therapy, that's focusing on stimulating the active effort of the client themselves. They are the ones that are active. They are doing the exercises, and by doing the exercises, they gain the profits from the exercises. The idea is to improve or to stabilize functionality. Unfortunately, there are some diseases that are regressive, so there is no an improvement possible. The only thing that you can do is try to stabilize the situation that they have and keep the functionality as good as possible for as long as possible. When you talk about exercise therapy, you should realize that from a physiotherapeutic point of view, you are focusing on the basic locomotory properties. And I will explain those later, what they are. You probably know them. And there's another thing that should be realized here. You can use exercise therapy in an individual situation, in a one-on-one situation with a patient, or with groups. And we sometimes get a group of patients who have the same injury or have the same disease. We put them together in a small group and then train the group, and that makes it more cost efficient, and it's also there's another important aspect is that they will have support from each other. That's an important thing as well. When you look at medical training therapy and you look at this picture represents actually the recovery during rehabilitation. In I'll ask to the technical lady at the site. Can they see my mouse? Or maybe I can ask Mustafa. Do you see my mouse move in the presentation? No. So if I move my, okay, you don't have my pointer here. Okay, then I have to explain. In the left lower corner, you see the gray arrow changing into a blue one. That's the part when the patient is first seen, when the patient is coming in. That's when you have a fresh lesion. The 100% in the upper left corner tells you about the recovery. So the red one, the red line on the left is the recovery line. You see this line going up, and that shows you in time patients will recover. And if you look at the pictures, on the left-hand side, you see the more so-called passive therapies. It's where you as a physiotherapist are using ultrasound, shortwave, or manual therapy. And the more the patient recovers, the more active they get, and the more specific exercise you are going to give. In the middle part, you see some pictures of exercise types that are focusing on muscle function training. And on the right-hand side, you see more the cardio training part. So this picture, shows actually the recovery process or the rehabilitation from an injury. So you start from passive, more preparing therapy towards exercise therapy in the end. When you talk about the equipment standards or the standard equipment that is sort of standard equipment that is in that is seen in an exercise room here in the training room. You see strength training stations, and I would like to emphasize the first part. We often as physiotherapists talk about strength training. I will make a change here in I'm more in favor of talking about muscle function training, because we're not only focusing on strength. We have a tendency as physiotherapists to focus on strength only, but there are so many more topics that you should focus on. When you talk about strength training or muscle function training stations, you should make a subdivision between the nature of the resistance, the adjustability of the resistance, the adjustability of the stations itself, and the freedom of movement. Those are important features to bear in mind. When you talk about cardiorespiratory training stations, that's something that we will discuss next week. At least that's the topic that is on the list for next week, or we should change that during after the presentation today. But I'm focusing on that more next week. Also there you have to focus on the nature of the resistance and the adjustability of the devices themselves. But you don't only work with devices. You also have the so-called free stations. They are not like actually stations or not machines, but that is exercise materials like free weights. I see there's an R missing in the first sentence. That's free weights. Other exercise materials like balls, like tubes with sand tubes or anything you'd like. And yeah, one of the latest things since, well, let's say 20 years, there's also computerized instructions, and there are training possibilities with screens and anything like that. The fourth point of a standard equipment is actually a patient registration system. Enraf has the N-Track and N-Train registration system. You use that for information and for instruction, and even you can use it for feedback. That is important if you have a training room where patients work their way around the different stations. You can easily preload training sessions on a card and let a patient more or less do the workout themselves, and you only have to walk through the room and give feedback and instructions to the patients when necessary. So it helps the patients to be independent, because in Holland we focus on letting the patient be as independent from the physiotherapist as possible. Here are some examples of Enraf-Nonius and dynamic equipment. I was informed that you have some of the machines that are visible here. Probably not all. It's just a short overview, but it's just an example. When you talk about the characteristics of medical training equipment, like I said, you should pay attention to the nature of the resistance and the adjustability of the equipment and the freedom of movement. Those are three characteristics that you should bear in mind when working with the machines. And in the end, you will connect them to the basic locomotory properties. When you talk about the nature of the resistance, there are several types of resistance. These two that you see over here are the most common. You have the weight stack that is actually still it's still used quite often. If you look at other manufacturers and actually all kind of exercise equipment manufacturers, they use the traditional weight stacks. A more modern approach is the pneumatic and hydraulic, and I'd like to express some advantages of the hydraulic versus the weight stacks. For example, if you look at the weight stacks, you just stick in the needle, the metal pin in the weight stack, and you increase the weight. When you have a pneumatic system, you adjust it on a screen, and everyone who has ever used a weight stack or trained themselves with a weight stack machine probably knows the phenomena that if you make an explosive motion, you see the weight fly up in the air and it sort of floats in the air and drops again, and then you get a sudden peak in power. Also, when you use a weight stack, the force that is necessary to start the motion is higher. The initial force is higher than with a pneumatic system, because the pneumatic system adapts the resistance to the speed of the movement. When you talk about rehabilitation, you would like to have the resistance as smooth and constant as possible. So that's why I prefer the pneumatic systems over the weight stacks. There are some other advantages. Like I said, it's an easy adjustable parameter. You just adjust it on the screen, and you can add small amounts of resistance, smaller than with weight stacks. Often they go in half a kilos or kilos or even 2 kilos, and in the larger resistances, it's often with 5 kilo steps. There are no peak forces in the eccentric and concentric movement. Like I said, the small steps I just explained. There's a fluent resistance, and there are fast repetitions possible because the pneumatic system automatically and immediately adapts to the speed of the movement. Specifically, pneumatic resistance is suitable provides a suitable range of resistance for rehabilitation. The most important thing that you do, or that you bear in mind when you do rehabilitations, you don't want to overreach your patient during the rehabilitation. So it's always, as we call, safety first. And yeah, there's another one. The final one is less disturbing noise, because if you have the weight stacks and if you're in an exercise room, you often hear the weight stacks slamming on each other. That makes a horrible sound. Okay. Another thing that you should be aware of is the adjustability of the equipment. It's often forgotten, so you should always pay good attention to establish a good training position of the patient, because that has a huge effect on the outcome of your training. One of the rules of the thumb that we have here is that you should adjust the equipment to the patient, not the patient to the equipment, which means that you should be aware and take the time to investigate the exercise machines that you have in your room, so you know about all the possibilities to adjust them. Every machine has adjustment possibilities. Those of Enraf-Nonius are adequate, and they're also limited. And limited doesn't mean that limited by means of that you do not have possibilities to find a good position for your patients. No, actually it's the contrary. You do not want too much adjustment possibilities, because otherwise you will lose too much time in finding the right position. The adjustability of the equipment should also be workable for patient and therapist. By that means, if you, like I said before, if you have too many adjustment possibilities, the patients will never be able to adjust the machines themselves when they work with them on their own. You should also pay attention to the amount of movement freedom. When we work as physios, we work in our programs in different movement planes. You have 1 plane, 2 planes, or 3 plane movements. In the early rehabilitation, that's the start of coordination training, and you focus on isolated movements, like you have a leg extension, for example, that's in one direction, only a concentric and an eccentric motion. That's often used to start learning the movement and to get control over the motion. The second step is to combine in two planes. You make a two-plane movement. That's also to improve coordination, but it's already a little bit more difficult. And in the end, you would like to work in 3 planes, and you make 3-dimensional movements. That's what we call the functional movement. So you start from an isolated movement and you work your way actually to functional movement and more difficult movement patterns. Like I said, you can focus on physical and mental functions. There has been some examples for where psychologists in the Netherlands using running therapy as a treatment for people who suffer from mental issues, and they found out that it was way more effective to run together with the patients and then have chats about their problems during the running than when the patient was in a treatment room, lying on a bench, having a chat with the psychologist. So it's not only focusing on physical functions, but it also has mental, positive mental effects as well. You should not underestimate that. Well, what is training? Well, due to training, the human body will adapt. The changes that occur are so-called adaptation rules, and each training should proceed by certain training rules and training principles. When you talk about exercise and talk about an exercise program, you should be aware of that it consists of certain components. And when you make a training program, you should be aware of the fact that by making choices in or a training frequency, you will get certain effects. When you look at the weight and the repetitions and you multiply those, you will get an idea of the intensity of your training. When you look at the size and the volume, it's actually more clear in the next sheet, because there I made it in the training schedule. Here you see a training schedule where on the left upper side you see the description of the exercise. There you can describe what the patient should perform. The second row is the one with the repetitions and the duration. You can either give an exercise with do 10 repetitions, or you could also say do the exercise for an X amount of time. The third row is the one about the series. So you do 3 series of 10 repetitions, or you do 3 series of 5 seconds, or 3 series of 20 seconds, whatever. The fourth row is the one with the pauses. There's the pauses between the series. The fifth one is the one for resistance and load. And the sixth one is the training frequency, is how often per week or per day they should perform the exercises. So when you multiply the numbers of the repetition duration and the resistance of load, you get an idea about the intensity of your program. When you multiply the repetitions duration, you multiply it with the amount of series, you get an idea about the size or the volume of your program. Of course, when you look at the frequency, you get an idea of the frequency of the program, how often they have to do it, and the type of activity can be described by the description of the exercise. You tell the patient, for example, to do a leg extension, but you can also describe how they should perform the leg extension, because you can make it a quick concentric movement and a slow eccentric movement, or a slow concentric movement and a quick eccentric movement. It helps you to specify your training program. And you already hear me say specify. That's already one of the training principles. Depending on the training goals, one needs to vary the training components in such a way that specific training effects will occur. So you should always do your assessment as a physiotherapist. You do your assessment, you do your intake, and you search for the disturbances in either range of motion, or in strength, or endurance, or you look for deficits in the performance of the patient, and you determine your goal for your training. in order to reach that goal, you should change the components of the training, so it will be directed specifically on that training goal. So the effects will be realized in that goal. So while creating a training program, you need to keep the training principles and rules in mind as well. There were days that every patient, if you wanted to increase strength, for example, also here, a lot of colleagues came up with we do 3 series 10 repetitions, or 3 series 12 repetition exercises, and they made it a standard. It will become clear that if you work like that, you will be less effective. You will get training effects, but they will not be as effective as you might want them to be. The training rules that are applicable during rehabilitation and sports as well is a principle of overload, ascending load, supercompensation, diminishing returns, specificity, and reversibility. Well, the principle of overload is often related to hypertrophia, but not only hypertrophia, also cardiovascular changes. You need a certain overload for your body to adapt. And the adaptations will only occur when a muscle is exposed to a larger resistance than is normally used to. So you should challenge your patient. The intensity must be at maximal levels for muscle strength and endurance before the changes will occur. And maximal levels mean maximal levels of the patient themselves. You have the principle of ascending load. A training program must contain a cumulative load, which means that the intensity of the load must be on such a level that it will lead to adaptations of the body. If you expose your patient to a certain load, you must make it a higher load in time in order to keep the progression continuing. Therefore, you have the principle of supercompensation. And the supercompensation is the body's reaction on fatigue. It's part of the normal physiological recovery process. And relaxation and rest are keywords here. We often have a tendency to stimulate our patients to put a hard effort in it, but you should also inform them that they should take pauses or should take rests so that the body can recover from your training. If you do not pay attention to that, you will overtrain your patient. On the other hand, if you give too much rest and relaxation, your training program will not be effective at all because the supercompensation the principle is not reached. The next training should fall in the so-called supercompensation phase. That is after full recovery from training, before the moment the supercompensation decreases. This has something to do with planning and periodizing. This is also something that has to do with the frequency of your training program. When you talk about, I made it clear in these next sheets. When you see in this next sheets, you see a combination of the principle of overload and ascending load. When you start, the blue block presents a certain amount of load, a certain intensity of your training. That will lead to fatigue. Your body will be fatigued by that training. You need to recover from that. And as a response on the training and the recovery, your body will go into a supercompensation mode, which means that it's adapting, it's making it stronger or more endurable. In that next phase, you need to come up with the next block of load. And as you can see, it's slightly larger than the first one. You follow the same procedure. And if I quickly go through it, you will see the increase in time. Here, the blue arrow shows you the upward arrow, and that's the improvement in condition or the improvement in performance. Then you have the principle of diminishing returns, and as seen in the next in the previous sheet, you saw this arrow going up like it's in a straight line. Actually, in real life, it's more a curved line. So and there the principle of diminishing returns kicks in, and that means that the longer you train, the more difficult it gets to realize further progress. When the training level increases, progress will decrease with an unchanged load. To say it in a more simple way, the better you get, the more difficult it is to improve. Maybe I should go back a little bit. You often see in rehabilitation, in patient situations, the early stages of rehabilitation, you get the largest progress and the quickest progress. That's often a very satisfying for the patients, because they put effort in their rehabilitation, and they get positive feedback because they see the improvement and it's going quickly. And the trick is to keep them motivated during the complete time of rehabilitation, because in the final part of the rehabilitation, the progress is less large. So you get less satisfaction for the effort that you put in, but that's a natural, that's actually a natural response. So to get the final part of the rehabilitation, to get the final part of your, to reach the goals of your final part, you should put extra effort in it. And the patients often feel it like they have to put extra effort in it. Then you have the principle of specificity. Then means that the programs must be created in such a way that the contents are similar to the function that is asked of the body in daily life, sports, or work. So you don't give just exercises for the quadriceps, or you don't give exercise to stabilize the back. You only give those exercises. You make them specific to the situation, what is asked of the patients in daily life or in work. If you have a sitting profession, you can ask yourself the question whether it's necessary to have a huge upper leg muscles being in top shaped condition. Maybe it's better to focus on those stabilizing, those small stabilizing muscles at the lower back, for example, to keep you in that upright position. The principle of specificity has something to do with the different types of training. In sports, it's often, when I jump back to the sports example again, if you want to improve on cycling, you shouldn't do a running training or rowing training. That will help you to improve your general condition or your general cardiovascular condition, but it's not focusing on the biking. So your biking will improve only a small part. This is often forgotten in rehabilitation. We, as professionals, often think that we know what's best for the patients. Well, I think it's even better to ask the patient, okay, and to get a good view on how they use their body and what they will need in their daily life. And you should, as a physiotherapist, professionally make a training program focused on that goal. Then you have the principle of reversibility. Once stopped with training, the effects will decrease or disappear. You probably know that. I often think it's the most frustrating principle, because all the effort that you have put into your body in getting better in shape, getting stronger, getting better at endurance, once you stop training, you will lose everything. And I personally think that's a development error in the human body. But okay, that's more personal, I guess. I think everybody recognizes this, that all the effort that you have put into it in your life, it's too bad. It's only effective for a certain amount of time. It's the use it or lose it principle, as we say it. Then we have to talk about the basic locomotory properties. And maybe you don't know the term, they're also called general fitness items. But when you move, with any movement that you do, you have to have a certain endurance, you have to have a certain strength, you have to have a certain movement speed or the velocity, you have to have coordination, you have to have mobility, the range of motion. And some theories also mention the brain or the psyche as a basic locomotory property, but in fact it's the first 5 that are called the so-called basic locomotory properties. When you stop training, the basic locomotory properties will disappear in a certain order. And I have to check if that works. No, that unfortunately doesn't work in this presentation. You first lose your endurance capacity, then you lose your velocity, then you lose strength, then you lose your range of motion, and at the end you lose the coordination. When you do rehabilitation, the first thing you regain is actually coordination, and that doesn't mean that you fully can coordinate the movement, but this is when you relearn. This is meant as relearning the motion, and this is where you start off with. You start re-educate. Okay, this is the movement that you make, and you re-teach the movement to the patient. The second thing that returns is the range of motion. Not completely, so it's not like an on-off principle, but it's often smoothly, sliding over in each other. The third thing that comes back is strength. Then you get your velocity back, and in the end, at the total end, you get your endurance back again. Training, you should also be aware of how to determine the correct training intensity. And this is where I will talk about in this third part. I look at the timer and I see it's 5 to 11. Do you still have some time? This will take about 15 minutes. Do you still have about 50 minutes, or do you guys have to leave? Otherwise, we have to take this part to the next time.
Yes, right.
Yeah. Please write it in the chat function. Okay, then I will take. We just accept a 15-minute delay here. We started later as well, so that's okay. We take this hour time. In this picture over here, it's a training intensity picture of training intensity in sport and health. This is not like a standard. This is just an example that I put in, but you already see an overview in, for example, they call it effort, but I also talk about intensity of your training program. You see already training goals. The lower gray one is focusing on mobility. Benefits is help with recovery and injury prevention. Yeah, it's about a 50 to 60% effort they put in here. When you look at it from a fitness perspective and sport perspective, these are intensities that you work with when you want to lose weight, for example, but that's not specifically a physiotherapeutic goal, I think. Now it can be when you talk about prevention, but that's another discussion. When you work on cardio levels, it should be on between 60 and 70%. When you want to work on strength, and that's to improve your fitness. When you compare it to sports, it's about 70-80%. And when you want to maximize performance, you go to 80-90%, or as they put here, the whoop ass. That's the bodybuilding, a massive intensity between 90 to 100%. These levels you will not reach with patients. You often work in rehabilitation. You work in the lower levels, but then still it is important to pick the right intensity. And to do so, you can use the so-called 1 repetition maximum. The 1 repetition maximum is the maximum weight that a person, once fully coordinated with a constant velocity of constant speed over a complete range of motion, can move. The speed of the movement during the test is determined on 30 repetitions per minute. That means 1 second up and 1 second down. That's actually the description of the 1 repetition maximum tests. There's also called a 10 repetition maximum test. You might know that. It's already a bit safer. That the 10 repetition maximum is the maximum weight that a person 10 times fully coordinated with a constant velocity over the total range of motion can move. The 1 repetition maximum is combined or is related to the so-called Holten diagram. It's already quite an old diagram, but it's still applicable. You should realize that this diagram is made or developed somewhere in the early 80s and of the late 70s, and it shows the relation between the repetitions on the right hand side and the maximum effort on the left hand side. For example, if you can do 1 repetition, like we said in the 1 repetition maximum determination, you reach your 100%. But you also probably understand that this is a high risk because you use a lot of weight, a lot of resistance. So it's quite difficult in a patient situation to use the 1 repetition maximum protocol. There's one other thing that you should be aware of. I'll take just a little sip of water. There's also a relation between this diagram and a measurement error. The more repetitions you will do, the larger the error percentages, which means that if you're in this example in the right lower corner, you see 20 repetitions. If you can do 20 repetitions, the weight that you are using at that moment is can be calculated by this number over here on the left hand side, the 167, to mathematically determine what the 1 repetition maximum weight is. I'll explain that a little bit later. But you should realize that there's a measurement error, and even with the 20 repetitions, you could be wrong for about 20%, even a quarter. It could be a quarter higher or lower. So it may not be as specific as you think it is, but it's even more specific than just putting your finger up in the air and just point the pin at a certain weight and see what happens. You should realize the original 1 repetition maximum test protocol is never used on and performed on patients because of the high intensity of the risk. It should only be used on healthy people and athletes. Okay, so we want to know the 1 repetition maximum, but we can't actually perform the test. How can we reach that idea then? Well, they've made a 1 repetition maximum determination protocol. It's a safe method to calculate the 1 repetition maximum of a patient. It's only to be used in patients because of the estimation of the 1 repetition maximum value. If you use this on healthy people, due to the measurement error that I spoke about before, you will not be as specific. It can be calculated, you can calculate the maximum weight, and the calculated maximum weight can actually differ from the true 1 repetition maximum. Once again, it's more specific than just trial and error, finding out what is possible in the patient. The idea behind this is the more repetitions, the less accurate the value is. In this protocol, you do 20 repetitions with a light or medium weight of resistance to pre-tone the muscle. You choose a weight, and that's where you have to, this is where the trial and error part is used. But you must choose a weight that will lead to fatigue and after multiple repetitions. It should not be too high or too low. Yeah, it's a little bit, it feels a bit easy to say so. But yeah, that's an estimation. You have to be as specific as possible. And let the patient perform as many repetitions as possible fluidly over the complete range of motion. So you look at more, you look at the different basic locomotive properties at the same time. The rhythm is, the movement speed is also determined on the 30 repetitions per minute, so 1 second up, 1 second down. And you abort the test when the patient starts to compensate. You take the amount of repetitions before the compensation occurs. So you place your patients on the exercise machine, you instruct them how to make this movement, and when you start counting the repetitions, and you track the weights that you've put in. Once you see the patient compensate, you look at the last amount of repetitions, and you can calculate the 1 repetition maximum. You have the weight, you have the percentage value, and you divide it by 100. And then this value is the estimated 1 repetition maximum on which you can base your training. For example, if your patient is able to do 40 repetitions, that means that your chosen weight is too light. If you reach 15 repetitions and the patient starts compensating from the 16th and the 17th repetition, you realize that the weight that you have chosen is 151% in this case. So is 1.5 times that weight that you've chosen is the theoretical 1 repetition maximum value. Why is this important? Because when you use any kind of muscle function training model, it's always related to certain training parts. And this is just an example of a training model. This is a training model that I have adapted some 20 years ago, made some changes in this. You can find 2,040 other training models. You should pick your own, which is most effective. I like working with this one because it gives me some structure. You'll be free to use it, but like I said, this is not the best training model ever invented. Training models will develop. There will be more, and even when we have this webinar, there will be 2 or 3 other new models being presented. So follow the developments in your work and in the theory. I use this 6-phase model as an example for a training session, but also in patient situation. You see 6 phases. You see it starts with the mobilization phase, then you have the coordination phase, then you have the strength. And I've subdivided strength in 3 subparts. In pure strength, strength velocity, those are the quicker movements, and the strength endurance, and then we have the local endurance. As you can see in the I must say, it doesn't necessarily mean that you have to start with 1, and then you have to go to 2, and then you have to go to 3, and then in the end you work your way through the model. It all depends on the goals that you set at the beginning of your therapy session. If your patient is looking for strength endurance because they need to be able to walk the stairs to the 10th floor because they live in a high building or in a large flat with has no elevator, you should work more on the strength endurance. If they do not have the capacity to move in a coordinated way, you should focus your early rehabilitation on the coordination as a preset factor enabled to make it to the next step, which means that you can jump from one topic to the other depending on the goals that you've set before. So it's not a certain order that you have to follow. The order is determined by the goals that you're setting. In the mobilization phase, the goal is to improve the local range of motion. This is often done in the early stages of rehabilitation. But if your patient can do this, you can already switch to other phases. You use 10 to 30% of the 1 repetition maximum. The repetitions are between 5 and 15. You have a minute pause between the series, and you do 1 to 4 series. As you can see, there are large ranges here, all depending on the capacity of the patient. Coordination in this model is used and is seen is focusing on the goal, the locomotor re-education, so relearning of the movement again. Once again, lower intensities between 10 and 35%, 10 to 20 repetitions, 30 to 90 seconds, so half a minute to 1.5 minute pauses between the series, and 2 to 6 series. For strength, this is focusing on increase of muscle strength. You see the higher intensities, and yeah, you might think, okay, when I go to 75 or 95% of the intensity, you should realize that the 1 repetition maximum is a measurement that will give you information of the maximum capacity at that moment in time. When you improve in over time, because yeah, that will be the effect of your training, your 1 repetition maximum will increase as well. So this is an important feature, that you do these 1 repetition maximum determinations quite often. At the early stage of rehabilitation, I often do a 1 repetition maximum determination twice a week, at the beginning, at the end of the week. In the next week, I do it twice as well. In the 3rd week of rehabilitation, I might do it once. This is something to do with with the progress in time. When we talk about the increase of muscle strength, repetitions between 3 and 12, minute pause, 5 to 10 series. You see the difference between the different variables. When you talk about strength velocity, that is focusing on increase of contraction speed. Those are the goal is to move in a quicker way. 60 to 70% of the 1 repetition maximum, you do, for example, 10 repetitions in 10 seconds, or you can do 10 repetitions in 5 seconds, which means that you have to move quicker. You give 2 minutes pause because it's more intense. People need to recover more from this kind of training, and you do 4 to 6 series. Then you have strength endurance. That's to increase the ability to supply strength throughout a longer time. Like I said, when you have to walk to the 10th floor in a flat, you have to have the power to walk all these stairs. You use a lower intensity. Your movement speed will be lower as well. You do 10 to 25 repetitions, 60 seconds pause, 5 to 8 series. The local endurance is to increase the carryability, 20 to 40%, 20 to 40 repetitions, 30 to 60 seconds pauses, and 3 to 5 series. Like I said, this is a training model. I don't say it's the best ever made. It works out fine for me. It gives me some solid ground to work from. Thank you for now. Then we will end the presentation and we end this webinar. And I would like to thank you for your attention.